extension of community healthcare outcomes for HIV and tuberculosis. We want to thank you all for joining us. Today, a brief welcome to all of you. If you can hear us, we kindly request you to wave, just to make sure we can all hear each other. Please wave if you can hear us. Okay, thank you so much. Thank you, Arthur Davidson Children's Hospital, Mulamba Health Center, Senanga, the HNP students, thank you for joining us. Mahatma Gandhi, St. Francis Hospital in Katete, Railway Clinic, George Health Center, Petaoke Urban, Ngombe Health Center, Matero Level 1, Choma General Hospital, Mwembeshi Rural Health Center, and the HIV mentors, the HIV TB mentors who are joining us all the way. They are in their retreat this week. Kalingalinga Health Center, Chipata Central Hospital. I know I've seen Jackson, I've seen Madam Lastina, I've seen Musonda from USAID. We see Mazabuka. Thank you so much. In the hub today, we are joined by our colleagues from the Pediatric Center of Excellence, Adult Center of Excellence, and we also have our colleagues from CDC. One of our experts today, the expert presenter, actually two of our experts are coming in from CDC. I'll let Dr. Keith introduce them. My name is Sombo Foloshi. I'll be facilitating today's session. Keith, you can go ahead. So before we go into that, we'll have a recap from Priscilla Makupe, who is one of the ECHO coordinators.
Last week's ECHO session was on rapid initiation of ART and patient preparation for lifelong treatment. Rapid ART initiation was defined as commencement of ARVs within 7 days of HIV diagnosis. We also talked about the linkage to care, which was defined as the first step in engaging in HIV care and is defined as the completion of the first medical visit within 28 days of HIV diagnosis. We talked about why same-day initiation is important. Some of the things that were discussed were it improves all-cause mortality, it also improves patients' immunological outcomes, then it also improves retention of patients, it also improves patient virological outcomes, as well as prevents HIV transmission. We also talked about barriers to same-day linkage, which was under patient factors, disease factors, and caregiver factors. We talked about barriers to retention and how to overcome them. We also talked about monitoring adherence through viral load. It was said that good counseling and good support will result into better patient outcome. Thank you very much.
Thank you so much, Priscilla. Just to emphasize that by rapid ART initiation, we mean the patient starts ART the same day or at least within the first 7 days. I'll allow Dr. Keith to introduce himself and the CDC team and go into the didactic.
Thank you very much and good afternoon all. So our panelists from CDC today, we have Dr. Mary Boyd. We also have Sam East from the Branch Chief Lab Services. My name's Dr. Mweebo from CDC, Public Health Specialist for PMTCT and Adult ART. So we'll go into our presentation. So learning objectives. By the end of this session, participants should be able to demonstrate understanding of the meaning of
You can go on, Dr. Keith.
Yeah, undetectable viral load in the context of U equal to U public health messaging. The next objective is to understand the benefits of U-equal-to-U messaging to HIV public health programs, as well as understand the meaning of U-equal-to-U messaging in the context of PMTCT. So to begin with, definitions of common terms. Undetectable equals untransmittable, commonly known as U-equal-to-U, is a global movement about how effective treatment as prevention can be if scaled up widely. What this means is that there is effectively no risk of sexual transmission of HIV when the partner living with HIV has a durably undetectable viral load. So the key words in this definition is that no risk of sexual transmission. We're emphasizing sexual transmission there. And another keyword is durably undetectable viral load. What's the question? So to begin with, we'll have our first poll question. Question 1, which one of the following statements is correct? Viral suppression, that's less than 1,000 copies per mil as defined by Zambia treatment guidelines, is the same as undetectable referred to in U-equal-to-U. Option B, undetectable in U-equal-to-U is the same as viral load results reported as target not detected. This is from the lab results. Option C, the threshold for undetectable viral load used in studies that informed the U-equal-to-U programming is less than 200 copies per mil. Third option, none of the above. So the poll has been launched. Can people start choosing the best answer?
Someone sent a text that the hub is on mute.
Oh, we are not. We're not on mute. Yes. No, we are not. Carlo, who's that? We are not on mute. Remember, we checked for everything. Which of the following statements is correct? Viral suppression, that is less than 1,000 copies as defined by the Zambia clinical guidelines, is the same as undetectable. Undetectable in U-equal-to-U is the same as viral load result reported as target not detected. The threshold for undetectable viral load used in studies that inform the U-equal-to-U campaign is less than 200 copies per mil, none of the above. We have 30 seconds more to poll. I'll just do a quick check. I'm told we are on mute. Can everyone hear us? Please wave. If people can hear us, can we please wave? People can hear, so I think, yeah. Thank you so much, that's helpful. Which of the following is correct? Viral suppression is equal to undetectable. Undetectable in U-equal-to-U is the same as the viral load result reported as target not detected. The threshold for undetectable viral load that used in the studies that have informed the U-equal-to-U campaign is less than 200 copies per mil, none of the above. I'm going to end the polling. As you can see, most people think that it's B. Most people think that it's B. Then a few people think that viral suppression is the same as undetectable. And some people feel it's C, that U-equal-to-U was informed by a study, the threshold was 200. Thank you so much. We'll go back to those again.
Okay, so moving on with our presentation, looking at the evidence behind U-equal-to-U messaging. So basically, for this presentation, we have considered the 4 studies: the HIV Prevention Trials Network, the Partner Study, the Opposite Attract Study, as well as the Partner 2 study. So you can see that beginning 2007, when the HIV Prevention Trials Networks was done in Malawi, Zimbabwe, South Africa, Botswana, Kenya, Thailand, India, Brazil, and the US. And the study population were serodiscordant couples, heterosexual and homosexual. And the study population in terms of sample size was 1,763. Then for the partners study, started in September 2010 and ended in May 2014. And it was done in 14 European countries. And it focused on serodiscordant couples, equally heterosexual as well as homosexuals. Then the opposites attract study, follow-up ended in 2016, and this study was done in Australia, Thailand, and Brazil. And the study population was serodiscordant couples and homosexual men. Sample size was 358. So we also have a partners 2 study that was building on partners 1, and it focused on serodiscordant couples, men, homosexual men, because this is where there is the highest risk of HIV transmission. And you can see that the outcome of all these 4 studies was 0 genetically linked to sexual transmission of HIV-1 infection among individuals with stable and detectable viral loads less than 200 copies per mil through use of ART. So in the next 4 slides, we'll just look at these studies in a bit more detail. So HPTN-052 showed that partners living with HIV and taking ARVs could reduce chance that the HIV negative partners would acquire HIV by up to 96%. The final analysis, which was done in 2016, showed that index partners followed for 10,031 person years. Partners followed for just above 8,000 person years. In this study, when we make reference to it, we will see that there were 8 linked partner infections diagnosed after index partner had started ART. But of all the 8 that were infected, none were virally suppressed or none were undetectable. 4 were diagnosed 90 days post-initiation and 4 got infection after ART failure. For those patients that were suppressed, there was no linked HIV infection reported within HIV-1 infection for those that were stably suppressed in the index participants. So for the partner study that was published in 2016, studied HIV transmission risk in heterosexual and gay mixed status couples as we indicated in the summary table. Partners living with HIV took HIV treatment and had achieved viral load undetectable. That is less than 200 copies per mil. So after 58,000 instances of condomless sex acts among over 1,000 participants, the conclusion was there was 0 cases of HIV accusation. Despite this evidence in 2016, the public health world really was still quite around the importance of 0 transmission for people who are stably virally undetectable. So in 2017, we had the publication of the opposite attract study that followed 358 serodiscordant couples in Australia, Brazil, and Thailand. And just below 17,000 condomless sex acts when positive partner had achieved viral load suppression, viral load undetectable, and by that we mean less than 200 copies per mil as the threshold defined by this study as well. And the outcome was 0 linked HIV transmission when positive partner was virologically suppressed with viral load less than 200 copies per mil in the absence of condom usage or PrEP. So the partner 2 study, which is a follow-up to partner 1, followed 783 male same-sex couples in 14 European countries and focused on men who have sex with men only. And the final analysis showed that 1,596 couple years were followed and then gives equivalence of evidence for gay men as a heterosexual couples and indicate that the risk of HIV transmission when HIV viral load is suppressed is effectively 0. So there was no link to transmission in 77,000 condomless sex acts among gay couples. The threshold for this study for defining undetectable was equally less than 200 copies per mil. So after this study, We see that now international organizations start responding to this evidence, and we had CDC come out in the open and say effectively no risk. This means that people who take ART daily as prescribed and achieve and maintain, so those are key words. We need to achieve viral suppression and maintain it. An undetectable viral load have effectively no risk of sexual transmitting the virus to HIV negative partner. So UNAIDS also came through and indicated that evidence was enough to public health programming to conclude that now once someone is virally undetectable in the context of U equal to U, there is literally no risk of transmitting HIV to the sexually to the HIV negative partner. So we are going to move on to the next polling question. In which of the following can U equal to U campaigns and messaging facilitate improvement in HIV programming? A, adherence to treatment. B, retention in care. C, demand creation for routine viral load monitoring. D, all of the above. Please choose the best answer.
In which of the following can U is equal to U campaigns and messaging facilitate improvement in HIV programming? A, adherence to treatment. B, retention in care. C, demand creation for routine viral load monitoring. D, all the above. We have a minute to continue polling. Some interesting answers coming up. You know what I love about the poll when you're looking at the results? If you have one person polling, that's 100%. Mm-hmm. So as more people poll, you see that the trend shifts. Mm-hmm. In which of the following can U is equal to U campaigns and messaging facilitate improvement in HIV programming? Adherence to treatment, retention in care, demand creation for routine viral load monitoring, all the above. I think it's a very good question, isn't it?
Yes.
Because U is equal to is all about the patient. So you need to be able to tell the patient the benefits. You know, what's the point of the patient knowing there's U is equal to U? Yes. Is it just a piece of information, or it can actually improve our programming? So we have 7 seconds left. Very interesting. Only 2 answers seem to be trending. I think it's impressive, actually.
Yeah.
So we have 62 people and facilities polling, which is good. In which of the following can U is equal to U campaigns and messaging facilitate improvement in HIV programming? Adherence to treatment, retention in care, demand creation for routine viral load monitoring, all the above. Yeah, the results. I'm sure you can see.
Yes.
Okay.
Okay, so moving on to our next slide, the benefits of U equal to U messaging for HIV public health programming. So the first one is it helps in removing stigma and discrimination. And we have 3 points there. HIV/AIDS as a terminal illness. People can no longer look at HIV/AIDS as a terminal illness, because once they are put on medication and they adhere on medication, they will be virally suppressed. They can live normal lives, and then they can no longer worry about being ill as a result of the effects of HIV. Then stigma on how the infection was acquired, as well as chronic infection signifies chronic infectiousness. The other aspect where U equal to U programming helps is around viral load. So there is more provider and patient understanding to the importance of why we should be doing a viral load, as well as creating demand for routine viral load. The provider also would like to know, is the patient I'm caring for undetectable? And then as a patient, they would also like to know whether they are undetectable, so that they can benefit from this. So they will be asking and demanding for a viral load because they want to know if they have achieved the U equal to U threshold. Then treatment priorities, it would improve enrollment, retention, and most importantly, adherence to treatment, because then patients are aware that U equal to U only works if you take your medicine consistently. So how to prevent HIV transmission to your partner? And this slide, really, we put it in speaking to the messaging that we are providing to patients. So take treatment daily as prescribed by the provider. Once you do that, once you are initiated on treatment, we expect that within 6 months, you achieve viral load under 200 copies per mil with effective treatment. And with the coming of dolutegravir-based regimens now, this could even happen quicker, even within 3 months. And then 6 to 12 months, we maintain viral suppression. And then by the time we are 1 year plus on treatment, we would have achieved the untransmittable state, and then continuous effective treatment and viral suppression so that this status is maintained. So answering key questions around the U equal to U, as you are aware, the national launch was done and provincial launches have happened. So one of the questions we get in the technical meetings was around the blood transfusion as well as protection against STIs and the messaging for condoms. So what we are saying is U equal to U does not apply to blood transfusion as well as to exposure to contaminated needles. Then U equal to U does not protect against other STIs. So we need to incorporate condom messaging for prevention of other STIs. So the next slide, we are trying to get our messaging correct in the context of mother-to-child, prevention of mother-to-child transmission of HIV. So does U equal to U apply to PMTCT? Is there a viral load threshold where risk of mother-to-child transmission is effectively 0? So these are questions that the next few slides will answer. But before that, we are going to have our third polling question. Which of the following is true? A, pregnant and breastfeeding women who are undetectable with viral load less than 200 copies per mil have 0 risk of transmitting HIV to their children or infants. B, risk of mother-child transmission of HIV for pregnant and breastfeeding women is significantly reduced or near 0, but not 0. So can we choose the best answer? So the first one says there is 0 risk of transmission, but the second one, B option, says it's not 0, but it's significantly reduced, but near 0.
One of these is true. Which one is it? Is it pregnant and breastfeeding women who are undetectable, that is a viral load less than 200 copies per mil, have 0 risk of transmitting HIV to their children? B, risk of mother-to-child transmission of HIV for pregnant and breastfeeding women is significantly reduced and near 0, but not 0. I like this question. It's less confusing than your first one. Okay, it's interesting. Wow, a lot of people are voting, and it's not a tie, but at least there's people who think both sides. So I think your next slide will be very helpful in clarifying it. Is it true that if you are undetectable, your risk is 0? Okay. Do we have evidence for that? Has that evidence been presented today? Or is the risk of mother-to-child transmission of HIV for pregnant and breastfeeding women significantly reduced, but not 0? So it's one of these. I hope in the hub we are voting. There's a lot of woolly waffling behind me. I hope we are voting as well. Okay, so 1 second left. And okay. So just to give people a glimpse of what our results are looking at like, I think our internet is a bit slow. So this is how we are looking at 15 and 85%. Thank you so much to those that voted. Okay, so findings summary on ART prior to conception.
So then, for the next slide, we are going to look at the evidence around U equal to U messaging and really how it applies to in the context of PMTCT. So this first slide looks at evidence for women who were on ART prior to conception. So we have included 3 studies, 2 done in France and 1 done in the United Kingdom and in the Republic of Ireland. You can see that the viral load threshold they used for these studies was less than 50 copies per mil. So for the first study in France, there was a 0 transmission. And then the second study in France, they used the less than 400 copies. There was also 0 transmission, same as the one in the United Kingdom for the threshold, less than 50 copies per mil. But you can see that there was transmission for viral threshold between 50 and 400 copies per mil, as well as above 400. Next slide. So for women initiating ART during pregnancy, this is where we'll have a change now. Even for threshold less than 50 copies per mil, these studies reported some infection. You can see that in France it was 0.5%. In South Africa it was about 4.5%, although they looked at a threshold of less than 400 copies per mil. And another study in South Africa showed that it was 0.25%. So for women initiating ART prior to pregnancy, the previous slide, it showed really that for viral, copies less than 200, transmission was very low, almost 0% in these 3 studies. Yeah, but then once we look at the group of women initiating ART, then these are initiating ART late, we see that we have some transmission ranging from 0 to 4.5% in South Africa.
So just to be clear, because this is a bit wordy,
So
on this slide, these women are not pregnant
when they start ART.
When they start ART. And if they are at a viral load of less than 50, they touch 0. These are not pregnant. They start way before they get pregnant.
Yes.
And then this group?
These are initiating ART was pregnant.
So these are pregnant, and none of them touches 0, no matter how suppressed they are.
Yes.
Thank you.
So even when we look at the variation in the confidence interval, these studies have shown near 0 risk of transmission. You see that when the mother is initiated on ART prior to conception, before she gets pregnant, and then she gets viral suppressed, the risk really is between 0 to 0.1%. So the conclusion here, next slide. The conclusion here is undetectable viral load is associated with very low but not 0 risk of mother-to-child transmission. And studies have really looked at a threshold, a viral threshold of less than 50 copies per mil. That's even less than the threshold we are using in the context of U equal to U for public health messaging.
Okay, so for pregnant, so much. We are going to allow some comments and any contributions from our network. But before we do that, we are going to relaunch the poll and allow people to vote again after you have taught. Which one of the following is correct? Viral suppression, that is less than 1,000, as defined in our guidelines, that's the Zambian consolidated guidelines, is the same as undetectable. Undetectable in U is equal to U is the same as viral load result reported as target not detected. C, the threshold for undetectable viral load used in studies that inform U is equal to U is less than 200 copies. None of the above. Okay, we have only 16 people voting. This is more about definitions. Do you want to talk a bit about the answer before?
We give a bit of time so they finish.
Okay. You're such a good person. For the second round, we give less time. Okay, so you're going to discuss these with us.
Yes.
Today, our case is coming from Western Province, and we are very happy to say that Precious is here because she was attending a meeting. I'm going to end the poll now and share the result. You want to comment?
So thank you very much. So clearly, understanding has happened because when we polled before the slides, majority of the people had chosen B as an option. So the correct answer here is C. As we saw, all these studies, really the threshold was less than 200 copies per mil. That is what it was defined as undetectable. But we are aware that for suppression for our guidelines is less than 1,000 copies per mil. So the second option, option B, really is a lab definition where when they run an analysis, they see that target not detected. Depending on the machine that they have used, it means the copies per mil are below the threshold where that machine can read or approaching zero. So clearly, the correct answer is C.
Thank you very much. We'll go to our second poll question, and I'll relaunch it. In which of the following can U is equal to U campaigns and messaging facilitate improvements in HIV programming? If you have an HIV program, you want to convince people to launch a U and a U is equal to U. In which areas do you think this message can have an impact in care and the program? Adherence to treatment, retention in care, demand creation for routine viral load monitoring. Then D is all the above. You may want to think of yourself as a patient, and you are told if your U is equal to U, it means you cannot transmit. It means that your risk of transmission to a child reduces, and obviously your progression to mortality reduces. How do you think this can be useful for the patient and for the program? Is it that they'll be more adherent to treatment? Is it that they are more likely to come back and get care, hence being retained? Is it that they are more likely to ask, what is my viral load? Isn't it? Instead of walking away and saying, as long as my CD4 count is 5. And then there's all the above. We have 61 votes. That's a lot. I'm going to end it now, and you can talk people through the responses.
Thank you very much. So here the correct answer is all the above, D. And clearly people did very well even before we shared the slides. So when patients are told the benefits of U equal to U, really it acts as a motivator for someone to remain on treatment. And for you to remain on treatment, you need to be retained in care. So you take your medicines every day. And then the key message there is they should have an undetectable viral load. So patients will come and demand for a viral load. So it creates demand for routine viral load monitoring. In addition to this, we also talked about the issues around addressing stigma. So these are some of the benefits of U equal to U messaging to public health programming.
Okay. So all of them are correct. So this is the third one, which we just learned about. Which of the following is true? That is, science has been shown, there is evidence to it. Pregnant and breastfeeding women who are undetectable, that is a viral load less than 200, have zero risk of transmitting HIV to their children. B, risk of mother-to-child transmission of HIV for pregnant and breastfeeding women is significantly reduced and near zero, but is not zero. Which of the following is true? So we have interesting votes on this one. So is it that if you are less than 200 and you are pregnant and breastfeeding, your risk is 0? Or is it that if you are pregnant and breastfeeding and you are undetectable, your risk is reduced but does not become 0? This is the last thing we were shown. So it's time for me to end the poll. Is it okay with you, Chris?
Yes, please.
Okay, so I'll share the results and then you can talk us through the responses.
Thank you very much. So we have done well on this one. 95%
Very well.
of the participants have gotten the answer correct. So for prevention of mother-to-child transmission of HIV, U equal to U messaging is very important. However, the message is not 0 risk of transmission. The transmission is significantly reduced, but near 0, but actually not 0. You saw from those studies, for women who start ART before they fall pregnant and then are virally suppressed, more so with the less than 50 copies per mil, the risk of transmission is very, very, very low. But we saw across those studies, it wasn't 0. We had 0.2%, and some of them are as high as 4% for the study done in South Africa. So significantly reduced when the number of copies are less than 50, but not 0.
It does not become 0. That's why we need to continue giving children ART when they are born to all HIV positive women. What will differ is the duration, because we know, now at least we know, it doesn't become 0. So they need that medication. So we'll take some comments and contributions from our network. Chatonda, are there any hands up? We have 5 screens, that's a lot. So we'll take some comments. I see Choma, you have joined us. Thank you so much. I know Edgar is not there, but thank you for joining us. Do you have any contributions on your experiences on the ground? Choma General Hospital, can they hear us? Oh, they are smiling. Please, would you like to comment on today's session? Oh, what's happening?
Yes, yes, Dr. Horos, you are able to get us.
We can hear you very well, thank you.
Are you getting us?
Yes.
Yes, thanks, Dr. Mweebo, for the wonderful presentation. Yeah, I'm sure the U equals U, since it was launched here in Livingston sometime this year, as a hospital, we have been trying to implement it. And I'm sure the benefits are quite many. Just as in the presentation, we are seeing an increase in the demand for viral loads. And so far, we have since bypassed our target, which we were given. And we hope to do much more better in terms of the uptake of viral loads, so that we can live up to the expectations in terms of the U equals U. Because we understand that viral load is very key. For as long as people are on treatment, they need to create a demand for viral loads so that we are able to monitor them properly on care. So thank you so much. I'm sure it's a timely presentation, and we have also enjoyed the studies that were done, the research which was done behind U equals U. Thank you so much.
Thank you so much. That was very helpful. So he says more patients are actually asking for their viral loads. I don't know if Sons of Thunder, I see Sal. Any experience now that we've launched the U is equal to U campaign?
I think out of all the women that we have delivered that have been exposed this year, there have been no positives. So the suppression is very good. And some of these women were even just based off of CD4s that were very high before we actually got the viral load results. So the guidelines that came out many, many years ago have proven to be definitely beneficial.
Thank you so much. Thank you so much. That's Kazungula, that's Sons of Thunder. Am I missing some hands? There's 5 screens now.
Livingston Central.
Oh, Livingston, please go ahead with your contribution, your question. Oh, perfect. What's happening? We can't unmute them. Okay, let me try.
Has his hand up.
CSO? Okay. Livingston, I feel like this happened when we first started ECHO at Livingston. For some reason, we cannot unmute you. So actually, we cannot hear you. Are you able to just type in?
They can unmute themselves.
Or try to unmute yourselves? Are you able to try to unmute yourselves? Oh, perfect. Just try. Nothing. Okay, what I'll do is I'll allow you to type it in, then Dr. Keith will read it out loud. Fred, please go ahead. And
yes. Good afternoon, Dr. Keith and Dr. Sombo.
Good afternoon.
Yes, I just wanted to find out on discordant couples. For couples that are on treatment and the couple that is not on treatment in terms of PrEP and in terms of U equals U. Does it mean that if someone in a discordant couple reaches the undetectable equals to untransmittable, for the partner who is on PrEP can stop using PrEP? That's my question.
Oh, thank you. Thank you so much.
Thank you very much. That's a very important and very good question. So, because you ask a question on discordant couples, so this is a question that gets answered when the couple presents in a clinical setting. So the public health messaging we are using is U equal to U. So when it comes to the clinical setting, really we would like to add an A to the first U. We say U plus A equal to U, and we say undetectable plus adherence equal to untransmittable. So the message would be around assessing how the suppressed patient is adhering to treatment. And then one of the things we advocate for is that the negative person in the couple acts as a treatment supporter for the positive one to encourage them to be taking medication on a daily basis. And as long as they have been suppressed and then they are during the counseling, there is no risk of like having other sexual partners from the part of the person who is positive and as well as the person who is negative. Clearly, we can say they can stop PrEP because we can confidently say that the risk of transmission sexually will be zero.
Is that okay, Fred? Is that okay? So I'm going to unmute Chongwe District Hospital. And we get some comments. What's been your experience since the U is equal to U campaign? Chongwe, can you hear us? You can wave if you can hear us. Chongwe District Hospital.
Yes, we're able to hear you.
You can hear us?
We can hear you.
Okay, any comments on the U is equal to U? Any contributions?
Thank you very much. The program has been so beneficial to us, and we are still following up on the viral loads. So which means we have done more than half of the clients. We have tested the viral loads. And at the moment, we are even proud to tell you that it doesn't take very long for us to receive the viral load results. It's just within 2 weeks and we have the results from the patient's files. So as a result, we are able to even switch the clients from the equivalence-based regimen to the tetra-based regimen. So we are really very thankful for this program because we are really learning a lot. We have learned a lot even today, and we are continuing to listen to you so that whenever we are lagging behind, we try to improve that. So thank you very much. Continue the good work.
Thank you so much, Chongwe. There is something very useful. Viral loads are important. They also help us transition patients to TLD. Mm-hmm. They also help us transition people to DSD models. They also help us with indexing of patients. And now they help us tell patients that your U is equal to U so that they are retained in care, they are adherent to treatment. Please, can you read what Livingstone has typed? They've been very patient. Oh, Livingstone. Okay, that's fine. I think we'll now move on. Or anything? That's
Jackson.
Oh, Jackson? I can't talk. I don't want to open the phone. I can't see anything. So there's a question here. Hi, can you talk about the difference between viral suppression and undetectable viral load, Jackson or Cook?
Okay. Thank you very much for that question. So if you look at the evidence, the 4 papers we looked at, and the conclusions in those papers, really these 2 words are used interchangeably in the literature. They use them interchangeably. But for the purpose of U equal to U campaign and the difference we have in our guidelines, undetectable, as we have heard, refers to a viral threshold less than 200 copies per mil. That would also be termed as suppression. So the only other issue is for our guidelines, viral load suppression as WHO guidelines and the Zambia Continental guidelines is defined as less than 1,000 copies per mil. And we don't really see a big difference in terms of public health programming, because you might wish to know that when we did Zambia in 2016, all those suppressed viral loads were analyzed. That is according to our guidelines. All the viral loads that were less than 1,000 copies per mil were further analyzed. And the good news is 96% of them were below 200. So for public health programming, there is not much difference that we can talk about in terms of suppression and undetectable.
Because we know a lot of them will be less than 200 on Zambia 2016.
Yes.
I'll let now Precious introduce herself as we go into the case, which is coming all the way from Western Province. For Livingstone, we will allow you to type your comments, because unfortunately we can't hear you. I think there's a problem with the way the speaker has been placed.
Good afternoon. My name's Precious Hatimbula. I'm a next TB HIV mentor for Mongu District. Western Province, I can see you. I know we have similar cases. The case is coming from Lioyelo Urban Health Center, but it would be good that everyone picks it and we can work towards the same goal. So today I'm presenting to you a case of a female aged 24 years who came to our MCH department on the 12th of June in 2018. That was for her first antenatal booking. Her expected date of delivery was 5th October 2018. On the same day, she came with her partner and we did test both of them. The woman tested HIV positive and the man tested negative. So the couple underwent counseling and the woman was able to understand and accepted ART initiation on the same day, including the husband who accepted to be started on PrEP on the same day. So we did our physical examination, that is for the last visit, kindly take note, where the height of the woman is 153 centimeters, the weight is 58 kgs, the temperature is 35, BP 120/67, the respirations were 18. Then for the partner, we did the height check, which is 160 centimeters. The weight is 60 kg, temperature was at 36.8, the blood pressure was at 127/68, the respirations were 18, and the BMI was 22. So we did baseline investigations, that was on the same day, the 12th of June 2018. Hemoglobin for the mother was at 12 grams. CD4 was 582. AST was 20. ALT was 16. RPR was non-reactive. And creatinine was 93. Take note that we did not do HbAg. Then also for the partner, we did, kindly go back to them. For the partner, we did AST, which was 17, ALT was 21, RPR2 was non-reactive, the creatinine was 103, and HbAg was not done as well. So when we look at our clinical summary, we include the baby as well, because the baby is alive. So for the woman, on the 19th of September 2018, we did a viral load, which came out to 151 copies per mil. She was virally suppressed, and that viral load was collected at 9 months in her pregnancy. On the 25th of October, that is the time the woman delivered, and the baby who was born had a DBS collected at birth, and AZT3TC NVP was given to the child. On the 17th of March 2019, for the woman, we did another viral load, which came out target not detected. The woman is virally suppressed, and the baby that time, that was at 6 weeks, the baby stopped prophylaxis but was given Septrin. So for the partner, on the 19th of September, an HIV test was done. It came out negative. We continued with adherence counseling to do with his medications, and the client continued to take his PrEP. On the 20th of December, we still did an HIV test. The HIV test came out negative, and we continued with the medication. And at that time, he still had no complaints. Again, on the 17th of March 2019, we did another HIV test. He continued on the same medication and still had no complaints. On the 6th of June 2019, we did another HIV test. It was negative, and the client continued taking medication, but this time he complained of being tired of taking his medication, which became a little worrying to the facility staff. So for the baby, the birth weight was 2.9 kg, and the first DBS, like we said, we did it at birth, which was 25th October 2018, and it was negative. Then on the 7th of December 2018, we still did another DBS. That was at 6 weeks. The DBS came out negative. At 6 months, we did the third DBS, which was negative. And on the 31st of July, we did a rapid test at 9 months. The baby came out negative. Currently, the baby is growing well and still is not experiencing any ill health and is breastfeeding. So we had 2 questions to ask from this case. Considering the viral load of the woman who is currently breastfeeding, because the viral load is target not detected, the woman is virally suppressed, could we consider that the man is no longer at risk and should therefore stop his PrEP? And also, should the baby, can we say the baby is no longer at risk since they are still breastfeeding, considering the mother's viral load? And the second question we have is, what special considerations are there for partners to pregnant and breastfeeding women when they are virally suppressed in terms of U equals U? Those are the 2 questions we have.
So before I allow questions, I'm just going to try and summarize the case. We have the case of a female, 24 years old, with her partner, who's 30 years old. This is a serodiscordant couple, HIV diagnosed while she was pregnant. Husband was put on PrEP while she was put on full ART. she managed to deliver a baby who was put on prophylaxis of AZT3T cineverapine. From all the tests, this child is actually HIV negative, though she breastfed the baby, and the baby is still breastfeeding. So far, woman is actually now target not detected with a previous viral load of 151. It's now target not detected. The concern here is that this partner, the HIV negative partner, is now saying he's tired of taking ART. Remember, wife is still breastfeeding. Their first question is, should they stop his PrEP? Considering the woman is still breastfeeding, and they also want to know, is this baby still at risk? We'll allow some questions from, we can stop sharing, from our network for Precious in case there's any need for clarification on this patient. We'll also allow questions from the hub, any clarifications from Precious. Or did she do such a great job? There's nowhere to poke holes. Any questions or clarifications for Precious? P. Makelele, please go ahead with your question.
Good presentation. I'd like to find out when they were talking to the partner after noticing that he was negative, did they go back to the woman to find out the issue of partner notification? Because there is somebody who gave that virus, that lady. Have they made an effort to go and track that source of virus? Because that was an opportunity to have a man on board. You know, we are having difficulty to reach to men, but that was an opportunity. And how did he react to find out that the man now, the actual partner, how did he react to find out that the woman who had the virus he did not have?
So I can respond?
Yes, sure.
So for the partner, when we look at index testing in this couple, we did follow up with the indexes, and some of them apparently, because the woman just came into Western Province in 2016. So some of the partners that she had encounters with are coming from other far places, others coming from as far as Namibia. So we have done indexing on this woman, and at least we have tried to exhaust. But the partner has been comfortable so far with supporting the woman on treatment. So the problem is only on the partner who is complaining of being tired of taking the medication. I think on partner notification, it has been well, and the couple has been coming together for every visit.
So that's our response. They have done index testing, though some partners were very firm, and the husband seems comfortable. I think we're not able to get more information on his emotional reaction because we know studies have shown that serodiscordant couples can have a lot of emotional stress because of that diagnosis. Would you like to comment on that, Keith?
Yeah, so that was a good question. I think usually, as we said in the slide, is one of the public health benefits of U equal to U messaging is that it removes this stigma around the source of infection. Because clearly, if someone is virus suppressed, then they cannot transmit the infection. And on the social aspects of life, we expect men also to react normally because people move from one relationship to another and they move on. So maybe at the time they were getting married, this woman was already infected. Yeah. So we expect a normal reaction, and just to congratulate the team at UL for having done a good job, that the man who is negative is actually acting as a treatment supporter to ensure that the woman continues to be on treatment. And this is what we expect in terms of programming, as opposed to a blame game.
It looks like this is the full package of what the HIV program can offer. There's PrEP, there's PMTC, there's ART. Maybe the only thing we missed is to maybe get on treatment before she got pregnant. Otherwise, this is very nice and we can see the positive impact. Any other comments or contributions from the network before Dr. Keith answers the question? Because I have a question that I've kept for Precious, but it seems she did such a good job that people are just waiting for. People are just waiting for Dr. Keith. Livingstone, I think we can hear you now.
Hello, good afternoon.
Yes, excellent.
Are you able to get me?
Yes, very well.
All right, okay. I just wanted to find out from Mongo, when they stopped the ARV prophylaxis in the baby, did they continue with the Septrin, because it's not coming out in the presentation? And then my question also to the doctor, to the presenter, that a mother who is undetected, a breastfeeding mother who is undetected, for how long should they breastfeed their baby? Thank you.
Thank you so much for your question, Dr. Keith.
Thank you very much. So to answer your question, according to our guidelines, we encourage breastfeeding. That's the option that we give women because of the other risks that comes with malnutrition and the risk of ill health when the child is not breastfed. So our encouragement in the guidelines is that for women who are living positively, they breastfeed the HIV-exposed infants, and we encourage them to breastfeed as much as they can. Most of the women in Zambia prefer to 18 months or close to 2 years. So really, their status doesn't change for how long they breastfed. We just encourage them to remain on treatment and adhere on treatment and remain viral suppressed. That's the more reason the viral load monitoring for pregnant and breastfeeding women is different from the general population who would like to know their viral load every 6 months, so that if anything changes, then we can intervene.
Okay, is that okay? So there's a question from Mulea. Please go ahead.
Okay. So it's just a follow-up. There's someone who asked a question, I think, over the viral load for the pregnant woman, which was 150 something. So that were there other sexual partners. So I was just thinking that maybe if Dr. Keith could explain to us on the viral bleeds in relation to that question.
So before Precious answers, I can answer.
Yes, it's for you.
Yeah, so thank you very much. So there has been a lot of questions around the viral blips. So to put it plainly, when a person is undetectable and virally suppressed, we are not worried about blips. In these studies that I shared, the partner study, there were 11 patients that had viral spikes during the term of the study. Even when the copies were less than 200 copies per mil, we had a few patients, 11 of them that had the viral blips where the viral load went above 200 and there was no infection. So in public health, for patients who are on ART and suppressed, even when they get a viral load blip, it will be a very 2-3-4D less compared to a blip for someone who is not on treatment. So the risk of infection remains very, very, very low. As such, with evidence we have now, we still say that U equal to U still remains. The only thing that is there is that the undetectable status should be consistent. It should be stable. So what we mean by that is you need to have 2 viral loads for you to say that it has been consistently undetectable. But the blips that happen in between, even in studies, they were there and there was no risk of infection.
Yeah.
just to redefine what a viral blip is, the classic definition is somebody moves from undetectable, they blip, which is a spike, though it's less than 1,000, then they go back to being undetectable. So that's the classic thing about a blip. Once it's persistent, it stops being a blip. So it's really a transient state. Priscilla, go ahead.
I'd like to ask a question. How often is the viral load monitored in breastfeeding mothers? How often do you monitor the viral load?
So thank you. I think this will be a question we hope to address in next week's session. But for our Zambian guidelines, it's every 6 months. So if someone is on treatment, as soon as they fall pregnant, the guideline for viral load monitoring changes. Pregnant and breastfeeding women, 1 viral load every 6 months.
So I think we'll now let you answer the first question, but the question for Precious regarding your patient. Most of the studies that were done when they are looking at serodiscordant couples and transmission, if you transmit, either you are not suppressed. But what was unique is that they found that some of these couples are not epidemiologically linked. Meaning you may have this woman, she's got HIV, she's undetectable. The man is negative, but he goes and picks up HIV from another partner. So did we bother to see if he's monogamous to this relationship? Because that would determine whether you stop him on PrEP. Because his wife may be undetectable, but you find he has other partners who the PrEP may be protecting him from. So did we get the history of his behaviors? What's his risk factor profile? Aside his wife, does he have other partners?
Okay, at the time of maybe drawing the case, those were the questions that we were asking ourselves, because the counselor who was attending to this couple was not around at the time. So we could consider following up on that also, so that we can have better reasons on why he should stop or if he should continue his PrEP.
So we don't know his risk profile aside the wife?
We can say so.
No, we don't. Okay, so Keith.
Yeah, thank you very much. So just to add on what Dr. Sombo was clarifying. So the U equal to U will result in prevention of HIV transmission from this woman to the negative man, because the woman is virally suppressed and actually undetectable. But what it doesn't do is protect this man from other sexual relationships outside marriage. So that is an important aspect that needs to be covered, such that in health education, we need to ensure that if there is such a scenario, he is protected by using condoms, or at least let him know that the PrEP is helping to that aspect. But in terms of risk from this woman, is totally zero. We are confident that the risk is zero. This woman has had 2 viral loads, both of them less than 200 copies per mil. And if we exclude any other factors and we assure the woman is adhering and the husband is a treatment supporter, because he will be motivated to support the woman because he wants her to remain undetectable, then we can confidently say that the fatigue he has on PrEP can be ended by stopping him from taking the medication, but having provided the health education around possibilities of infection from other partners outside his marriage.
Okay, any comments about the breastfeeding child?
Then for the baby, as we have heard from these slides, the mother is undetectable, but the baby remains at risk. But the risk is very, very, very low. So the baby needs, the clinic needs to continue monitoring this baby as an HIV-exposed infant, providing continuous counseling as well as testing at the scheduled time point. So until we get a final outcome after the baby stops breastfeeding. As long as the baby is breastfeeding, the baby remains at risk. But that risk is very, very low, as we saw in those studies, compared to the risk around women who are not virally suppressed.
Thank you so much. So we have a lot of comments before you answer our second question. There's a question. How does U is equal to U help reduce stigma and discrimination?
Yeah, so we had 3 bullet points under how U equal to U messaging helps reduce stigma and discrimination. First of all, in the olden days, HIV was perceived as a death sentence. Once you get HIV, there was no hope. But now we know that when people are put on treatment and then they become viral suppressed, they can live normal lives. There is also an issue of perceived stigma and self-stigma. If you are in a discordant couple, you are always worried to say, I may pass on the infection. But now we know that these people can live normal love lives without really having to worry about infecting their partners. Secondly, they can also have children. This thinking around, I'm now HIV positive, I will not have children. They can no longer be worried because of U equal to U messaging. And then, the stigma around HIV comes from the fact that an HIV-infected person can infect others. You remember in the olden days how people used even to give them their own cups, their own plates. We know that once they are virus suppressed, the risk of passing transmission is very low. So we can look to these people as normal human beings and have no reason to discriminate against them.
Fred, would you like to contribute to that? Fred Chungu, or have we lost? Do we still have Fred? Fred, do you want to contribute as to how U is equal to U contributes to reduction of stigma and discrimination? Is it there?
Yes, as the doctors alluded to, it is mainly to do with people not accepting, of late, people are not accepting their status. Hence, they were saying they couldn't have children. But as the doctors alluded to, now people can have children due to the U equals U. So that has reduced a lot on stigma.
Mm-hmm. Thank you so much, Fred. Have you seen any difference in the way patients are taking this news? In terms of stigma and discrimination, do they feel relieved?
Yes, actually, a lot of people now are getting on treatment. They are adhering to treatment due to the message that is going around to do with U equals U. People now know that once they have a reduced, once they have a reduced viral load suppression, they can still have babies and can just live normal lives. So as a result, people are now coming to accept the U equals U, and the stigma around that is now reducing.
Thank you so much, Fred. We have Abraham Nelson Piri. Are you able to unmute yourself? Abraham Piri. There's a question. For U is equal to U in terms of stopping PrEP in a negative partner, should the undetectable viral load be done only once, or over what period should the viral load be undetectable before the negative partner stops PrEP?
Hello?
So the question is for how long? The question is for how long should the patient be undetectable before we can advise that PrEP be stopped, after looking at all the circumstances around the social support, adherence to treatment, and the presence of other sexual partners outside the relationship under discussion. So we saw from that slide where I shared timelines on key messaging. So 0 to 6 months, we expect them to be suppressed. 6 to 12 months, they remain undetectable. And by 6 months, if we should be doing a viral load. And if that viral load is undetectable, at 12 months, we'll be doing another viral load. That viral load is undetectable, we'll have 2 viral loads. Then we have evidence of the undetectable status being stable. So at that point, then we are good to say that the negative partner can be weaned off PrEP.
So we have a comment from Clarence. Clarence, are you able to ask your question?
Yes, I'm able to ask a question. Hello, can you hear me?
Ed, you've typed in something. Go ahead with your comment and your contribution.
Yeah, my comment to the team that presented was, you see, for a patient to really follow our prescriptions and everything, there's really need for clear guidance and clear communications to them as in, for example, how long they'll take it and what determines them to stop and everything. So for this patient to start, for this partner to start complaining, say, I'm tired of taking these drugs, was there a clear communication to him to say, okay, you will take this medication for so long and for this reason and everything? I think that's my question. Hello?
Precious, that question is for you.
I think I'm confident enough to say the counseling that was given to this couple was adequate in terms of the treatment preparation for the woman and also for the PrEP, how long the man would take the PrEP. We just got consent, and I think it's also one of the happenings in our ART departments where clients would verbalize maybe fatigue or taking medication because they're taking it on a daily basis, and maybe someone would feel like stopping on one day, have a break or something. So maybe for him knowing that he's HIV negative and the woman, he understood to say when someone is undetectable or someone has a viral suppression, he can stop the PrEP. So I think that is where the concern is coming from. That is where the fatigue is also coming from. So we best needed to know how we can handle the couple so that we know the way forward for the man. That's why we came up with the question.
Okay, so there's a question from Alec. Alec, do you want to unmute yourself? Zamona, Alec. Alec Zamona has a question. I think the question is, with this talk around viral load, are there any plans to have point of care viral load machines? I think Dr. Tina and, do you want to answer that one? Do we?
I will. Can you hear me?
Yes, I can hear you.
So right now, we do not have approval for use of Gene Expert or, thanks. Can you hear me better now? Right now, we do not have approval for use of either Gene Expert or MPEMA for viral load. That is something that we as a program advocate for and are working with the ministry to obtain.
Okay, is that clear? I know you refer to the Gene Expert and PMA. I know we commonly use the Gene Expert for sputum, but Gene Expert can actually be used for viral load, which makes it a point of care or near point of care. The same goes for the PMA, but these are point of care tests, but we do not have approval at the moment. I wish we were joined by Tina and from the U campaign. We had asked them to join. So for now, there are plans, but they are not approved yet.
Thank you.
Thanks. Mr. Kalele?
Yeah, Patrick Makelele.
Yes.
Yeah, I want to react to that, but there's some validating studies which have been carried out here in Zambia for the point of care viral load. So I don't know why we should wait, because if after dissemination and the technical working group from the lab have accepted, why should we delay such a demand? Because for me, viral load, actually we are just lucky our patients are not well educated. People should be overwhelmed if the patient were educated on viral load. So the demand is quite high. I don't know why the Ministry of Health should hesitate and wait so long while the validation that has happened in this country, dissemination done in this country. What should I wait for?
Yes, thank you, Mr. Makelele. I think you are very, very right. These tests have been done. I know Livingstone did for EID, and the Gene Expert can carry out these tests, but there are processes that the Ministry of Health has to follow before they actually move to full implementation. But you are very right. These machines can do point of care viral loads. And I think the ministry is aware of the urgent need, as you put it. Thank you so much. Precious, please go to your second question.
The second question is asking, I think I've lost it also. Okay, so we are saying what special considerations do we have for the partners to the pregnant and breastfeeding women, for those that are already suppressed in terms of U equals U?
Okay, thank you very much. So no unique or special considerations. This applies to all discordant couples. First of all, in terms of the PMTCT program, we would like women as they come for HIV testing, also their partners to be tested so that if there is any discordance, it can be identified. It could be the man who is positive and the woman is negative. So at that point, the woman is put on PrEP and then the husband is put on treatment. And then the message should be the same. We want them to be consistently on treatment until they are virally suppressed. That way, the risk of transmission to the negative partner is significantly reduced. It actually gets to zero when we get to undetectable status. In addition, this is also beneficial for the HIV-exposed infants because, as we saw, once if it is the mother who is positive, once she is undetectable with the copies less than 50 per mil, then the risk is near zero, but not zero. So the considerations around discordant couples in pregnancy is not different from other discordant couples. The only addition really we want to make in terms of the PMTCT program here is there are cases where the status of the man is not known, but the woman has tested HIV negative. We should make an assessment on the risk of the man based on how the woman is perceiving the partner. And if there is any risk that we perceive in the partner, for example, if the partner is having multiple sexual partners, the status is not known, consideration for PrEP for the negative woman should be made.
Thank you so much, Keith. Are there any other contributions? St. Francis is saying, what information is currently available to explain why the male partner could not get HIV regarding the period they have been together? Why didn't he get HIV in the first place without PrEP? St. Francis, it's a good question.
Yeah. So it's a very good question you have asked, Andy. When we were reviewing these papers, part of the slide we could have shared that we didn't share is a slide which shows risk of HIV when one is positive, one is not negative. As you know, it's not 100%. If it was 100% risk of HIV, then a lot of people would be positive. So the risk is really not 100%. So people estimate that it's 1 in 1,000 for every sexual exposure. So you see that the risk is highest amongst homosexual men, and then heterosexual transmission is way, way lower. So that's why we have discordant couples. Even before treatment was readily available, we had people who would be in a relationship for 4 or 5 years, they're staying together, one couple is positive, one is negative. So the main issue is the risk is not 100%.
Thank you so much. So we have, I know Namakau, you've raised the question. I don't know if you mind bringing it up next week because we'll be discussing it because I'm now running out of time. But Alec is saying that the problem is that the PrEP pack looks very similar to the full ART pack. Do you think there would be benefit in making them different so that it's more appealing to go for PrEP so that people don't think you're on full ART? I guess one has less stigma than the other. Alec, do you want to elaborate before? Alec Zamona? Okay, so he's saying, can we make them different?
I think can I clarify on that?
Yes, Mr. Makelele.
Okay.
Hello?
Patrick Makelele at FHI 360. Now,
yes,
the issue of PrEP, having the same packaging with ART, it's bringing some literacy confusion in the community in a way that there are even cases where people are sharing drugs because when they live in the same house with the person who have taken care of it, they're the same drugs I'm getting. So we can as well share or just take them. Me, I'm not HIV infected. I think these are your drugs, not mine. That's the element which Alec is bringing out, the issue of literacy and packaging of the PrEP.
Thank you so much, Mr. Makelele, for clarifying that, actually. Do you want to comment on that?
Yeah, so as part of public health programming, one of the aspects that where our program needs the improvement is patient literacy. So providing health education for people to understand health issues surrounding their health. And we are lucky because now at Ministry of Health, we have a health promotion unit that is working very hard to ensure that we have messages and we improve on patient literacy. Some of it should happen at facility level as we are dispensing drugs. So it should be very clear to patients that even when the packaging is the same, the drugs inside are different because one has 2 drugs, the other one has 3, so that patients do not use these drugs interchangeably. In the case that we had today, we had the woman and the man are coming to the clinic and being seen at the same time. That's the best scenario we would encourage because then it can be explained to say these 2 drugs are different. I think it's a matter probably that we can share with the procurement unit and see if there is avenues for manufacturers to package the PrEP drugs separately in a different package.
I think it's very important.
Okay, I think there's a question on whether you tested the index partners as their comments. I think you said they tested. People want to know what were the results of that lady's index.
That would be like going back to the registers and all. I think I may not have most of their results. They were quite a lot. The woman has had her own past. We were even suspecting at some point that maybe she should have been one of the key pops. So I can't really say much on their results. Yeah.
Okay, thank you so much. I know Namakau has a question on the HIV-exposed infant and DBS testing. When you should do the DBS, should you do a rapid test? I think we'll push that one to next week. We'll be dealing with it. We'll keep it there. I think one of the things that has come up is there's a lot of demand for viral loads. So we may have to really quicken the process of approving the point of care test. Validation has been done already. So I think to summarize, Precious, since you are here, I think, Dr. Kit, you want to just summarize the recommendations in 2 lines for her patient and the partner, the PrEP considerations.
So in summary, we would say that this person is acting as a treatment supporter for the woman who is taking ART and she has remained undetectable. So we would say that if taking medication becomes an issue, we would be comfortable to say that this person has no risk of sexual transmission of HIV from the partner, from her, because she's actually undetectable. However, we should address the issue of whether or not this man, there is a potential for this man to have other sexual partners outside marriage. And then we should continue monitoring the HIV-exposed infant until final outcome is determined after 6 weeks or after cessation of breastfeeding.
Thank you so much, Dr. Keith, Dr. East, Dr. Boyd, and thank you so much, Precious. That case was, it had everything in it, didn't it? Thank you to all our network that contributed, and we'll see you next week. Next week, we'll be discussing viral load monitoring in pregnant and breastfeeding women. This topic was actually motivated by the fact that when we go in facilities, we are finding that viral load women who are pregnant and breastfeeding are being regarded as ordinary people. That you are not talking about 2 lives. So we are finding there's a lot of lapses in viral loads, and people are not aware that this population needs more frequent viral load monitoring. Even after the baby is born, as long as they are still breastfeeding, the viral load is not like the cascade for the general population. That's it. We will see you next week. Thank you so much. HW21 sites, for the past 3 weeks, we have not received your registers. Please submit them to Mr. Henry Sichinga and Mr. Davis Kampamba. See you on Monday next week. Thank you.